For those of you that weren't aware, we're doing a webinar today, so we have to be tethered to the microphone here so that those people on the other end of the computers can actually hear us, assuming we have something they want to hear. But as Joe said, I'm with the Unico part of the Alliance, and for those of you that maybe came to us because of the Midlands invite, let me just give you a quick brief background. Unico is a large property casualty and financial benefits organization based in Lincoln with 4 offices in Nebraska. Our Columbus manager, Bob Wick, is here today. We've got an office in Kearney and one in Metro Omaha. And then we have regional offices in Kansas City and Denver that do certain program business for us. Unico as an organization takes a lot of pride in the culture and the way we work with clients. And we knew that to be the case with the way Midlands does their business. I happen to have a unique perspective because when I owned my own business, Unico did all of my property casualty and work comp insurance, and Midlands did all of my benefit and retirement plan business. So as a client, I respected both organizations for what they brought. So today we have this alliance, and we just wanted to share 2 or 3 slides with you as to what it means. Why are we doing it? What is it? How's it going to look? Well, basically, the alliance is something that was put together, as Joe said, about 6 months ago. It's not a merger. It's a strategic alliance bringing together resources from 2 organizations to improve our ability to connect to, support, and entice clients to understand what's happening with things like healthcare reform and other things that affect your businesses and ours. Because it's not a merger, there's no real ownership of one company buying the other. There is an involvement and resources being placed in a technical thing called an LLC, kind of a holding company, if you will. But basically, it's our ability to come together and bring more expertise that you all might benefit from and that we hope we can put on the table. The Unico Midlands name is a brand we're rolling out. It's not one that's really in use. You've kind of seen parts of it through some of the material we've sent out. Our branding efforts are behind the scenes, but will be coming out. But our people are what's out in front. Ryan and Joe and Leanne and all the folks you know from Midlands, Linda and Kip and Gina and myself from the Unico side, we're all working together in the same building, having daily and weekly meetings, trying to understand what's happening in the marketplace and try to make sure we're up to speed with what you need to make good business decisions as you move forward with your HR and your benefit programs for your respective employees. We expect that there's going to be a lot of synergy with this. We know we don't have all the answers yet, but we're learning them. And with our industry partners like BlueCross and BlueShield, we're able to bring a lot of things to the table that up till now maybe weren't as prevalent. Some of the things I've already talked about, but we know that Unico is going to bring to the table 20-some producers that work in work comp insurance, work in commercial insurance, and work in a lot of specialty areas that a lot of people have come to know us over the years. We know that Midlands has state of the industry in terms of retirement plans, in terms of benefit plans, in terms of consulting for companies, and a lot of the things that you need on that side of the house. And by putting them together and having access together, we think we'll be stronger with a deeper bench and one better able to respond to the kinds of challenges and opportunities you have as business owners and as managers of respective companies. You know, today it's all about coming together, learning, working with our industry partners, and figuring out what is this thing that we call healthcare reform. We were talking to a consultant 2 weeks ago who happened to be on the staff of the United States Senator Grassley from Iowa, and he made the statement that I thought was rather profound. He said, as much as what's been talked and written and shown about healthcare reform, he has yet to meet anybody in Washington, D.C. that understands it. Now think about that for a minute. He was in the halls of Congress. He was working for a U.S. Senator. He's back in Nebraska now as a consultant. He believes no one there really understands it. So how could you all possibly understand it? But hopefully you're here today to learn a little more, to gain a little more insight, and to help yourselves make the decisions that are appropriate. So with that, I think we're going to turn it over to Tracy for introductions for the BlueCross team. Tracy?
quickly because Michaela is the main, one of the main speakers here because she's been going over the healthcare. I just want to say real quick, thank you so much for coming. We have a full house. There's familiar faces, so good to see you back. Real quick on your table, just a few things. National Walk is our 7th one this year, April 24th. You should be getting more emails from either Midlands or from us giving you some more stuff on how that's going to work this year. Everybody should have a copy of the presentation as well, the PowerPoint today. And then as well as everybody on the webinar, because we should have about 35 people that's logged on to the webinar. So if you are on the webinar, you can do for questions. We ask that nobody really ask questions during Michaela's speech just because it's pretty lengthy. And then afterwards, if the people on the webinar want to do the chat, they can do it that way. If we have time, we'll certainly take questions here. If not, we'll try and get them answered and then get them back to you later, if that works. But there's a couple handouts that everybody on the webinar we hope have as well. Share responsibility, provisions, questions and answers, employers, and then some other stuff on the 90-day wait. So again, everybody should have these. Just wanted to remind everybody, we've got to tell you on our wellness. A lot of the lunch and learns that we have that we can certainly offer, ask Midlands about them. They're pretty much no cost or $50 per lunch and learn. Maternity, I think everybody's pretty familiar with maternity is now on your group at no cost, so we're not going to really solicit this at all to your members. They'll get it in their welcome packet, but it's up to you to get this flyer out to your employees. And just one other community health program. Just wanted to let you know what Nebraska BlueCross BlueShield does across the state of Nebraska. We have several health fairs that we're putting up. So if you have any groups or employees in North Platte in the month of April, they'll be having a wellness fair in the North Platte area. And then in North Fork, it would be in the month of June. And then in Kearney and Grand Island would be in September. And then Lincoln, Omaha in November. If this is something that you kind of want to push out to your employees and let them know that this we're putting this health fair on, let us know and we'll give you some flyers and stuff. Or let Midlands know and you can certainly get you some flyers made up so you can help promote it. And then I think maybe you're all familiar with our partnership with US Able. It's also a Blue Cross association plan as well that is owned. So now you can also have life and disability on with your medical as well. So with that being said, I want to introduce Michaela Valentine. She is Director of Governmental Affairs. And we get her in Lincoln here sometimes, and then she's in the Omaha office. So she's going to present today on the healthcare, and is going to answer, I'm sure, all of your questions and make it super easy and fun. Okay, I got to fix this up a little bit because I've got to be able to see my slides. If those of you on the webinar cannot hear me, will you please send a message into Kim? I had to rearrange the podium so I can see my slides. Okay, first the fun stuff. I'm going to stand over here so that I can kind of see everybody. Like Tracy said, my name is Michaela Valentine. I've been working at the Blues for 6 years, mostly doing healthcare reform since 2009. So we've actually been working on the law before it even passed, so in its bill stages. So, and even though I've been working almost exclusively on that for almost the last 4 years, I don't know everything about it either. And you're going to be hard-pressed to find somebody who does. But the goal of today is to hopefully bring you a little bit more clarity about it and to give you some tools to look at, some of the handouts that we have that we'll go over. It will give you something to talk with Unico Midlands about when you're making plans going forward about how you're going to cover people. So my role here today is not to give you individual legal advice. So I have to give you that disclaimer. This is not legal advice. I will not be able to answer questions about your specific group because I don't know what product you're on or how many employees you have or any of that. But I am going to give you some of the basic tools that came out in the regulations to work with and show you where some of the law has changed via regulation, and hopefully just give you a little bit more guidance and some information to help you get along in this strange new world. So today we're going to talk about the exchange, the health insurance marketplace, employer responsibility, a 90-day waiting limitation, and essential health benefits. I think that's everything that we're probably going to be able to just cover in an hour's worth of time. Now I want to tell you and be real clear about this. that everything that I show you today that's on a slide is just the tip of the iceberg. I'm going to give you very general information. So even though you're going to look at it and say, okay, this is the rule, it's not necessarily the rule of law. IRS tax code is highly complex. I am not a tax attorney, and I'm assuming most of you probably aren't either. So just remember that everything you look at, there's always going to be caveats in the law to that or exceptions to that, and pages of regulations that go with it. And I just want to be really clear about that so you don't think that what we show you today is the end-all, be-all, and you take it back and use it. You're going to still need to consult with people like Unico Midland to make sure that they've got you on the right track. And we work really closely with them as well. Anything that we hear that's new about healthcare reform, we work with them and pass things on down the line. So we have a great collaborative relationship and are constantly working together to get you guys the new information that we can. Okay, so first we're going to talk about the exchange. Has anybody in here ever heard about the exchange? Let me see hands. Yeah? Okay. So now that you just learned this new term, exchanges, they went and changed the name on you. Now you got to call it Health Insurance Marketplace. On January 17, 2013, healthcare.gov, which is the HHS site for healthcare reform, issued a statement that exchanges are now going to be known as Health Insurance Marketplace. And it's basically a marketing rebranding effort to make it a more consumer-friendly term for folks to understand that you really can purchase insurance in the marketplace. Exchange doesn't really mean much to anybody. It's an exchange of information between carriers and brokers and Health and Human Services and the IRS, but it doesn't really mean anything to the people that are out there purchasing it. So what they wanted to do was do a rebranding effort, sort of get away from the term exchange because it's become very political, much like the term Obamacare versus whether you call it Obamacare or you call it the Affordable Care Act or the Patient Protection and Affordable Care Act. So this is just a rebranding effort. So going forward, when you see this term, Health Insurance Marketplace, pay attention to it because they're talking about exchanges. So if that is something that in your future is going to impact what you're going to be doing with your group, that's what it is. I want to back up a little bit and talk about what Nebraska did, just so that we're all on the same page about what we've got going on here in Nebraska in terms of the marketplace. And you'll have to excuse me if I refer to it as exchange, but it's been the exchange for 3 years, so I'm just getting used to it. But on November 15th, Governor Heineman, he chose a federal health insurance exchange, citing increased costs on Nebraska taxpayers. The state exchange was estimated to cost $646 million over the rest of this decade, which is 2013 up through 2012, and the federal exchange would cost only $176 million. And Governor Heineman said, because we don't know what the federal government's going to do, and we're just not sure what their plans are, we're just going to give it to them and let them take care of it. Now, a couple of years ago, he did the same thing with what's called the PCIP program, and that's the Federal Comprehensive Health Insurance Program. He let the feds administer that too. So we were suspicious that this was probably coming down the pike, that he'd let the feds run this too. And that's because, rightfully so, the information we have now is not enough to be able to do a lot of buy-in on what the feds are going to do. So he just said, we don't want to know any more about it. We're just giving it back to you guys. Now, the numbers as far as how much it costs, a lot of people take issue with that. They weren't so sure after seeing the press releases that it would really be that expensive. But one of the things that we can do as a state, first of all, I want to go back to what our options were. Our options were a federal exchange to be run by the federal government. The second option was a partnership exchange to be run by the federal government and the state in a collaborative effort. The third was to run a state-based exchange, which the state would run by itself. And the fourth was a regional exchange that could be a bunch of states that get together and run an exchange. Okay? A lot of folks in the state were pushing for a state-based exchange because they wanted to keep everything live and local. Consumers who have issues wanted to be able to talk to Nebraskans about those issues. And quite frankly, it's a lot easier to get a hold of the Nebraska Department of Insurance than it is to get a hold of the federal folks. So knowing that, the governor knew that a lot of folks really wanted a state-based exchange, but he made the decision, for the reasons I stated earlier, to go with a federal exchange. And so one of the things that we can do as a state is reserve the right to come back and take this back to a state-based exchange. Hypothetically speaking, if state government was to take a look at these cost figures that you see, $646 million versus $176 million, and say, you know, we really overshot the cost of this. It really isn't as expensive as we thought, and we think we can do a better job as a state. The state can come in and take back the exchange or the marketplace. They can submit a letter to Kathleen Sebelius, who is the Secretary of Health and Human Services at the federal level, and say, hey, we want to go ahead and take the exchange back and run it as a state. Now, we have to give 12 months notice in order to be able to do that, so I don't see that happening for some time since we just gave it to the feds. But it's, you know, it's not necessarily a foregone conclusion that the feds will keep it forever. There could be an opportunity that we as a state could take that back. That being said, to the consumer who is shopping on this insurance marketplace, the interface, whether it's a state-based exchange or a federal exchange, is not going to be vastly different. It's going to look the same no matter what. On the back end, who runs it and who has sovereignty and control, that's where the difference is of the state versus federal exchange. Are there any questions about that before we move on? Yeah, okay. So states have until February 15th to choose a state and federal partnership. That was a date that was set out by HHS. There were various dates that were set out to choose a state-based exchange or a federal exchange, and the partnership exchange is the one deadline that we have left coming, that a state could theoretically make a choice for a partnership exchange. To date, 18 states plus the District of Columbia chose a state-run exchange. 20 states chose a federally funded exchange, which is called an FFE. Nebraska chose a federally funded exchange. 7 states chose a partnership, and 5 states have not made an official decision. So that's where we line up as a nation as far as who chose what for whatever reason. One thing that I want to bring up is exchange notification. A lot of employers have been working with their brokerage firms such as Unico Midlands and asking, hey, we heard about this thing that we have to notify our employees about, the exchange, on March 1st, 2013. Well, that has been delayed. There was a January 24th, 2013 frequently asked questions document that announced that they are delaying the exchange notification until further notice. So any of you that were worried about this March 1st deadline, you do not have to worry about it. You'll learn in later regs and notifications what you need to do. It's sort of a complex process about how they issue these types of notifications. HHS or Treasury has to talk to the Department of Labor and give them the language that they want them to use. The Department of Labor then puts it into a template and makes an announcement. And so none of that's going to happen. And the reason why is because looking at how things are set out in process with open enrollment starting on October 1st of 2013, they thought it would be not in the best interest of the consumer to issue an exchange notification so far away from open enrollment because folks might forget about it. So the plan is to issue the exchange notification closer to October 1st of 2013 so that the consumer is getting all of their information at once about the exchange in a timely fashion, and then they can go and enroll in it. Any questions about the notification document? I know that you'll be hearing more about that from Unico Midland when that comes down. So look for that to be end of summer, early fall. Okay, we're going to talk about user fees in a federal exchange. To fund the full cost of the federal exchange, participating issuers will be charged user fees.
For 2014, we got to pay a monthly user fee to HHS at 3.5% of the monthly premium charged by the issuer for a policy under the plan. Now, that rate might be adjusted to conform with state exchanges, but right now, I don't believe that's the case. And states can still accept establishment grants to build Medicaid interfaces with federally facilitated exchanges. So that's kind of where we're at right now, and this is the hot topic of what's going on with federal exchanges. But you knew there was going to be some fees and things to pay for it, and I know you guys know there's other taxes in the law as well, but you've got to be able to fund the cost of the federal exchange, so this is one of the ways that they're going to fund it. Okay, we're going to talk a little bit about employer responsibility, and this is where it starts getting kind of complex. Again, I want to say this is just the tip of the iceberg. The slides I'm going to show you, there's a lot more about, in the proposed rules, about look-back periods and counting hours of service. It's 144 pages long. I don't know if anybody's had an opportunity here to read those proposed rules. I guarantee you it's great bedtime reading if you need to get to sleep. But we'll go over some of the highlights of it today. Okay, this is the overview of the employer mandate. In 2014, employers with a certain number of employees will be subject to the employer shared responsibility requirement, and that's also known as the employer mandate. Sometimes you'll see it abbreviated as the ESR. The requirement goes into effect on January 1st, 2014. Proposed regulations are out with comments due by March 18th, 2013. And so what that allows us to do is anybody can comment on these proposed regulations. You all can, we can, but it allows us to talk with folks who are going to have to do this work every day and really talk about what implementing these regulations look like in a real world, because that's always the rub with regulations. Yeah, it sounds great, but then when you make a statement in regulation, then you'll have 40 people who will say, well, that doesn't fit how we do it, or this is going to bump up against something else that is problematic in the Affordable Care Act. And so the federal government has requested those comments so that they can make any kind of changes that need to be made in the final regulations and then issue those. And once the final regulations are issued, that's it. So this is the time to make comments and to work with Unicode Midlands if you have issues, so that everybody can kind of take those issues and send them up to the federal government for comment. Okay, the employer mandate is sometimes referred to as the employer pay or play. So I wanted to put that in there too, because depending on how you think about it, there might be a different term, but it's all the same thing. But the first step is that you have to understand the rules. And I want to show you the second bullet point here, but before we talk about it, I want to caveat this with, in the proposed rules, this has been changed. I wanted to show it to you so that you understand and see it as something that you're used to seeing, and then we'll talk about how it's been changed in the proposed rules so that it makes sense to you. It's not a major change, but it's something that you'll need to be aware of. So the original rule is if the employer has 50 full-time employees, which is full-time, 30 hours a week or 130 hours a month, and offers no coverage, the penalty is $2,000 per employee per year, and that's $166 per month, so 1/12 of $2,000. If any employee receives a subsidy in the exchange, minus the first 30 employees. So under this one, if you're not offering coverage, you use the full-time employees minus the first 30 formula to figure out how much of a penalty you would owe. Part-time employees are calculated by taking hours worked by part-time employees in a month and dividing by 120. So 30 hours a week divided by 120. 30 hours a week times 4 is 120, I'm sorry. Seasonal employees are not counted if they're working less than 120 days in a calendar year. So how do you determine your number of employees to figure out if you're an applicable large employer? That means, does the penalty apply to you? A large employer is one who employed an average of 50 full-time employees on business days during the preceding calendar year. Again, you have to take into account part-time employees as full-time equivalents. So to calculate part-time employees, you're only calculating this for the determining if pay or play or the employer mandate applies. This doesn't mean that you have to offer coverage to part-time employees. You do not have to do that. So you take the hours that the part-time employees worked in a month, divided by 120, and that will give you your full-time equivalent. Here's an example. A restaurant has 20 part-time employees who all work 24 hours per week or 96 hours per month. These 20 part-time employees would be counted as 16 full-time employees. 20 part-time employees times 96 hours worked in a month equals 1,920 hours divided by 120 equals 16 full-time equivalents. So this right here tells you that you can't just look at the blank number of, do I have 50 full-time employees or not? You really need to, if you're right around that 50 number, you really need to walk through and figure out how many part-time employees you have, because you'll see right here that for the purpose of determining if you're a large employer or not, you've got to count those part-time employee hours. Okay? Okay. So determining full-time status with ongoing employees. You want to figure out which employees are full-time. A full-time employee is somebody who works, on average, 30-plus hours per week. For ongoing employees, the IRS proposed a 3 to 12-month standard measurement look-back period selected by the employer to determine the individual's full-time status. So if you don't know somebody's full-time, you can go back a year, 3 to 12 months, and look at their schedule to see if they actually qualify as 30-plus hours a week. If you do determine that they're a full-time employee, the employer must offer coverage during a subsequent stability period of at least 6 months, but no shorter than the standard measurement period. So you got to do at least 6 months. If your measurement period was 8 months, then you got to do it 8 months on the back end. So you're going to have your measurement period, whatever that is, whatever you decide. There's an administrative period of 90 days that you can have in there too between the measurement and the stability period, and that's for you to figure out the results of the measurement period and say, okay, this many employees are full-time employees. I'm going to have to offer them coverage going forward and get them ready to offer them coverage. Or this many employees are not full-time employees, so now in the stability period, we don't have to offer those people coverage. So that's why they set out the measurement period for you to look if you're unsure if you've got some folks that are full-time employees or not. Questions about that? Are you still with me on this? Yeah? No? No? Go ahead.
So say our policy is 35 hours a week, and the government's saying if they average 30 hours a week, I've got to change my policy to go with what the government says. I'm following you.
If your policy for offering health care coverage is 35 a week?
Basically, our internal policies get thrown out the window, and we have to follow the federal guidelines.
Yeah, I mean, for determining if you're an applicable large employer, it would have to be, the 30 hours a week. And if you meet that threshold, you're going to have to offer them coverage if they're determined to be full-time employees. Now, are there caveats to that? I mean, there might be. I can't speak specifically to your group, but just the plain letter of the law, the way that it reads, yeah.
How you determine the selected by the employer their look-back period? What do you
So,
with there?
So if you have a look-back period where you might have somebody working a heavy amount of hours, but it's not really normal in the course of ongoing business, you don't have to use those months. So if it's just kind of a fluke, and for whatever reason you have a lot of people working really heavy hours, you can not use maybe that month or those 2 weeks or whatever and use a different period. So they do give you some flexibility to do that, but again, that's something that you're going to want to discuss with Unico, and we'll give you some guidelines that you can work with too in trying to make that determination. Again, just the tip of the iceberg. There's a lot more about how you count hours and you measure hours of service, so this is just very general information here. Okay, now we're going to talk about determining full-time status. Here's an example of how you can do things. For January 1 plans, an employer could choose a 12-month measurement period beginning October 15th and ending October 14th. So you can't go over the whole year date. You've got to be one day short. You can use an administrative period between October 14th and January 1st to make your decision from your measurement period to say, okay, now these people measured, I'm going to take this time to determine if they are actually full-time employees or not, and then you can make plans going forward in the stability period, which is the 12-month stability period beginning on January 1st and ending on December 31st, to offer those full-time employees coverage. Now, the administrative period can be used to identify the full-time employees. That's what it was. Before, in previous issues of the regulations, they just talked about the measurement and the stability period. And a lot of employers came back and said, I need time between there to figure out how to offer these people insurance before I can just go into the stability period. Now, there are some caveats that come with the 90-day administrative period. It has to overlap to some extent. So, again, you're going to want to take this for what it is, just very general information that these 3 different periods exist and that you need to be aware of them. Okay, now we're going to talk about variable hour or seasonal employees. You can use an initial measurement period of 3 to 12 months to determine average hours worked. If you determine that this variable hour or seasonal employee is full-time, then you use the stability period that is consistent with the one that we just looked at. It's got to be at least 6 months, but it's got to measure the first measurement period. It's got to be 6 months or more. And that's what you would use as your stability period if you determine they are full-time employees to offer them coverage. Employees become ongoing employees after the initial measurement period and a full standard measurement period, meaning you measure them, you have an administrative period, and then you have a stability period to offer them coverage. So now we're going to talk about calculating the penalties. So how do you know if you owe a penalty? Again, we referred to this a few slides ago. You have the full-time employees minus the first 30 times $166 a month equals your penalty. Penalties are calculated on a month-by-month basis, and employers are only subject to this penalty, this specific equation formula that we're looking at here, if they're not offering coverage and at least one employee receives a subsidy in the exchange. For this particular penalty, you use the total number of full-time employees when you're calculating this penalty. So this is the penalty for not offering coverage. Okay? Now, if you are offering coverage, you need to figure out if your coverage is affordable. If you offer insurance and it's not affordable, and an employee can go to the exchange and receive a subsidy, then you're gonna pay a penalty. Unaffordable means that the employee portion is greater than 9.5% of income. Now that's what's reportable in box 1 of their W-2. It's unaffordable by that particular standard, meaning greater than 9.5% of their income, or their coverage doesn't meet the minimum value, which is 60% actuarial value. The penalty is 1/12 of $3,000 or $250 a month for each full-time employee who receives a subsidy in the exchange. Now the next bullet is a topic of a lot of controversy. The 9.5 affordability test used to be applied to household income. Once they figured out after issuing the law that employers were going to have a heck of a time trying to determine what somebody's household income was, they issued language called an affordability safe harbor. And what they said in that is, we're not going to look at household income. Instead, what we're going to look at is 9.5% based on the lowest cost single coverage. So it's employee only lowest cost single coverage. Now one of the issues that comes up is, how do you extrapolate that to family coverage? Well, they haven't issued anything on that yet. So for right now, this is what you rely on, 9.5% affordability based on lowest cost single coverage. Doesn't matter if the coverage is just for the employee or for the family. This is the test that you use. And if this is confusing or controversial or any of that, I hear that from everybody that I present to. How do we do this? This right here, this 9.5% is going to be the thing that's in the forefront of your head when you're, trying to figure this out. We have talked and talked and talked about this on end, and I think we're going to continue to talk about it. I think we'll hear more after the proposed regulations, in the final regulations, if anything is going to change on this particular issue. So, again, proposed regulations, not final. Here's a summary of the penalties. You're only going to be penalized if you're not offering coverage and you have 50 or more full-time employees, which including part-timers. Remember I said you have to count the part-timers to calculate if you're a large employer. And you have one or more employees that receives a subsidy through the exchange. All of that has to come together for an employer to owe a penalty if they're not offering coverage. Now, you could be penalized for offering unaffordable coverage if the employee portion is greater than 9.5% of wages and the employee receives a subsidy. There was some language that split the difference in the proposed regulations that said if an employer offers minimum essential coverage, which would meet the 60% actuarial value requirement, but it's still unaffordable, they might not have to pay a penalty. And so I think we'll see that fleshed out further in the final regulations, but that's something that is in the works being discussed. Okay, we're gonna talk about 90-day waiting limitation in a minute, but before we do that, I want you guys to pull out this document if you've got it. It is the IRS document, Questions and Answers on Employer Shared Responsibility Provisions under the Affordable Care Act, and it's dated December 28th, 2012. And the reason why I wanted to pull this out is to save you from reading that 144 pages of proposed regulations. This document asks what I think are some of the most important questions that folks can read to get a general overview of where they need to be in terms of making sure they understand the proposed regulations. And it is a few pages long, but I got to tell you, for the IRS, I would say it's not incredibly difficult to understand, and it walks you through a lot of the basic questions that I hear from folks when I present about what are the provisions, who do they apply to, how do I know if I'm a large employer, how do I calculate the penalty and count hours, how does the IRS interact with me if I owe a penalty because I either didn't offer coverage or didn't offer affordable coverage according to that 9.5% threshold. But I think you should, I wanted to give this to you, and I can't even find this on the IRS site myself. I had to have somebody find this for me. I think it's important that you know that it came from the IRS, because a lot of you who might be more savvy in following this, this whole issue of regulations on healthcare reform, you may realize that a lot of what is put out on CISIO, which is the Center for Consumer Insurance Oversight and Information, doesn't cross-reference with the IRS. So everybody's issuing their own regs and putting it on their own website, but nobody's cross-referencing anything. So if you go out to CISIO, you won't see this. And that's sad, because this is an important piece of information for you. When you take this back home and read it, I think you'll agree, yeah, this gave me more information than I had before, only you won't be able to find it where you think you're going to be able to find it. Because depending on whatever the regulation is, you could get your regulations issued by the Department of Labor or IRS or HHS. So just be aware of that. So this is a very coveted document, but I'm sure we can get you the link to it if you need it. The thing that I want to point out to you that we talked about earlier is I said the penalty has changed a little bit, and it changed in the proposed regulations, and that is under question number 10. So if you would all go to question number 10, if you can see that, I want to point out to you the language that was added in this particular provision through the proposed regulations. What had happened is these folks at the IRS received comments back from employers saying, how many people do I really have to cover? You know, is there going to be any kind of leniency at all, or does it have to be 100% of people? And so what you'll see in number 10 is when we talked about the employer penalty earlier, under sub A, when you look at your piece of paper, it says the employer does not offer health care coverage or offers coverage to less than 95% of its full-time employees. That language, to less than 95% of their full-time employees, you will notice was missing from the slide that I showed you earlier. And I specifically wanted to show you that slide and this language so that you knew that this was the language that was not in the earlier version of the penalty. This is the new version of the penalty. So going forward, the new version of the penalty is under question number 10. The language that was added is to less than 95% of its full-time employees. Please make sure you're aware of that. It applies to both not offering coverage and offering unaffordable coverage. So that's the new language, and it changes the calculation a little bit in that you're going to have to now discern if you are offering coverage, if you do not offer health coverage or offer coverage to less than 95% of its full-time employees. So that's the difference. Okay? The other thing that I want to point out to you is that under number 12, how does an employer know whether the coverage it offers is minimum value? A minimum value calculator will be made available by the IRS and the Department of Health and Human Services, and it will work in a similar fashion to the actuarial value calculator. It will allow employers to input certain information about their plans, such as deductibles and copays, put that into the calculator, and receive a determination as to whether the plan provides minimum coverage. And we, BlueCross BlueShield, will help you with that, but I wanted you to know that in case you want to get out there and see, once this calculator is made available, that if it applies to you and if you're offering minimum essential coverage, that's something that you can do on your own. Right now they have the small group piece of this done, but they're working on the large group minimum value calculator. So I don't know that it's available yet, but we'll receive notification when it is, and we can pass that on to you folks as well. Another thing that I wanted to point out is a lot of folks have questions under number 18. There's a discussion of transitional relief. I want to bring this one to your attention because a lot of folks that I talk to want to know, when do these provisions apply to them? And although I cannot interpret this for you, I would encourage you to read it as it is on its face, because I think it will give you the information that you're looking for. It appears to say that if you are on a plan year in 2014, that you don't have to comply with those provisions until you hit your plan year. Okay? So that's one that you might want to read, because it buys folks some time if they need some time to make some adjustments and you don't have a plan year that hits until later. So that's one thing that you might want to take a look at. But this document is very helpful. I encourage you to use it as a point of dialogue with Unico Midlands so that they can help you with your individual different plans and policies and work with you to get your goals accomplished as far as what you want to do on the employer shared responsibility payments. The other thing I wanted to tell you that I found encouraging that I wanted to share is that the Congressional Budget Office just issued an economic outlook that was released on Tuesday, February 5th, and it suggested that people won't be ushered into the health insurance exchanges as quickly as previously estimated. So one of the highlights of this that I thought was important to share with you is that they believe that more people will remain on employer-based coverage for longer than they previously expected. So I think that's good because it says something about stability in our marketplace. And I think it also speaks, although not directly, to the value of employers offering coverage and how important it is. And one of the goals at the beginning of on the outset of the Affordable Care Act when this was becoming law was they wanted to keep people on employer coverage. And that's why you'll see, if you're eligible for employer coverage or if you're eligible for a government assistance program, you're not a person who is able to go into the exchange and get a subsidy because they want to keep you on employer coverage. Now, they're going to penalize you if it's not affordable. So I know there's that whole thing, like, why don't you guys just leave us alone? But that's how it works. So they want to keep you on employer coverage. If you're on, Medicaid, Medicare, VA, TRICARE, all of those government programs, they want to keep you over there. And then they just want to get the people in the exchange right off the bat that will qualify for the subsidies and be able to go through there. So that's how the overarching picture of who goes where on coverage is supposed to happen. That's the theoretical picture. We'll see what happens going forward. Questions before we talk about 90-day waiting period? Okay, are you guys still with me? Okay. So I wanted to refer you to this handout. This is a 90-day waiting period handout. It came down on August 31st of 2012. I don't know if that date is on there for you, but it might be important for you to write that date down because if they issue any more guidance and you go and retrieve that guidance, you'll want to know what came first, what came second, so you can keep it all straight. This guidance remains into effect until the end of 2014, so you can rely on it until then. For plan years beginning on or after January 1st, 2014, a group health plan or health insurance issuer offering group coverage insurance, health insurance coverage shall not apply any waiting periods that exceed 90 days. So that's what this whole document is talking about what is 90 days, how long can you, how long can you wait to offer insurance before you have to get them on there. And this applies to group businesses and grandfathered and non-grandfathered groups. Okay, go back here. So let's take a look at your handout. This is temporary guidance. And like I said, it remains in effect at least through the end of 2014. And they have the option of extending it on if they decide that this is their final guidance in this area. The one thing that I wanted to mention is on page 2, you'll see that the waiting period is defined for you so that you can read about that, and it tells you how to apply the particular rule on 90-day wait limits to variable hour employees when you don't know if they're actually going to work 30 hours a week, or you don't know how long they're going to work for you, and if you have to offer them coverage. So one of the things you might notice right here is that there's an intersection between offering the penalty of offering coverage and not offering coverage and the 90-day wait period. So although these are two separate areas of law, they come together. And so this is where they converge under sub B. So I just want to make you aware of that so you see that there's so much interplay between the various aspects of the law as written. And a lot of this was sort of like an afterthought of, oh yeah, well, there's going to be some interplay here, so now we got to figure out how to make that happen. So this is how, under sub B, this is how they talk about determining variable hour employees in relation to the employer shared responsibility payment, and that is duly noted in here as section 4980H. That section refers to the section in the law that speaks to the employee shared responsibility provision or the penalty for the purposes of whether you're offering coverage or not offering coverage or offering unaffordable coverage. The thing that I really like about this document is it gives you some great examples to walk through here. There are some common examples that the IRS came up with on the 90-day wait period and when you would apply it and when you need to offer somebody insurance and when you don't. So I would encourage you to take a look. There's 4 examples there, and I would encourage you to take a look through that document. Now, as far as the time period for requesting comments, that has finished. So this is what you can rely on going forward. I think BlueCross, our current policy is that we, right now, current policy, we have a wait period for new policy issuance, and it's the first month following your hire date. So it's a 30-day wait period. But in order to meet federal guidelines, what we'll do is if a group decides they don't want to go with that, we will go with whatever the group decides they want to do, but we have to do the cutoff of the 90-day wait period. So we're willing to make changes on that. It's not in our benefit contracts, it's in our master group application, but that's something that we will work with the group on if they decide that they need to make that change. Okay, so that's this document. I would encourage you to read it in your free time. Now we're going to talk about essential health benefits. This is a pretty controversial topic right now, and I'll tell you why here shortly. But there are 10 categories of benefits that must be included in individual and small group products. You can see these 10 categories listed here. I would point out to you that the most controversial topics right now in determining the essential health benefit package are what is habilitation and what are we going to do with pediatric, dental, and vision services. Those are the two hot topics. In Nebraska, make sure I'm not getting ahead of myself here. In Nebraska and in any other state, we were given 4 options by Secretary Sebelius to pick from what we wanted our health plan to be. And it was, it was like the largest HMO, which nobody's ever even heard of. And it was like the most prevalent small group product. And it was the federal plan. And then there was one more category. And what the Department of Insurance did was they held hearings to take people's comments on what they thought these packages should look like. And really what the hearings turned out to be were a lot of special interest group folks coming and saying, we think you should include our special interest in the habilitative category. So those are what the hearings look like. And just to give you an idea of what I'm talking about, one that seems to come up over and over again is the coverage of autism spectrum disorder. Okay? So you might have some folks come and say, we know that autism spectrum disorder coverage, like applied behavioral therapy, for anybody who's familiar with autism therapies, that's one that's not covered today, and they want that one covered, so they believe that should be covered under habilitative. The term habilitative is to get you to do something you've never done before. So for example, if you had an autistic child that maybe didn't speak before and you could get that child to speak through therapy services, you might be able to classify that as habilitative. So that's just an example of something that would go under habilitative. The problem is no one covers habilitative. There is no insurance company that covers habilitative because it's a newly created category under essential health benefits. So Governor Heinemann sent his submission of the essential health benefit package, which was a high deductible health plan, and it was actually a BlueCross plan. I believe it was option 20. He sent that to Kathleen Sebelius and said, we want to do this. And she rejected it. And the one thing you should know, it was very confusing that it was a high deductible health plan, but that was his way of saying, this is how much you all are going to have skin in the game as individual people on a high deductible health plan to get all of this coverage. So it was sort of a political statement. But Kathleen Sebelius came back and said, I am rejecting this. This is not within the 4 choices I gave you. We gave you 4 distinct choices, and since you did not choose one of the ones that we asked you to choose, you have now defaulted to the largest small group plan in the state of Nebraska. So now our Nebraska's essential health benefit plan is Blue Pride option 5. So that's where we stand today. Again, Blue Pride option 5 does not cover habilitative. So we are currently working with the Department of Insurance, and we sort of have to come up with some recommendations about what should be covered under there, given the goal of having people do something that they've never done before. So we're in the process of trying to figure out what should be covered under the habilitative category right now and working with our Department of Insurance. So that's kind of what's going on in the state on essential health benefits. The essential health benefits, that's going to be effective for plan or policy years 2014 and 2015. And large employers are not required to implement, but they must not impose annual or lifetime dollar limits on essential health benefits. Now, please understand that essential health benefits, whatever the package is, including what we do with habilitative and pediatric dental and vision services. That's only going to be the package for possibly 2 years, because in 2016, HHS Secretary Sebelius has the right to, she reserves the right to come back and change or update the package, okay? So this could change. We haven't completely figured out how it's going to work yet, but this could change in another 2 years. The reason that pediatric dental and vision services are so complex right now, and it's an area of focus right now, is because there is this thing that you have to offer the standalone dental vision products and the exchange, but yet it's still a piece of essential health benefits, so we are mandated by law to offer it as well. So we're trying to figure out the coordination of, do we really have to offer it if we can pair up with a standalone product, or do we not have to offer it? And that's something that we're working on with the Department of Insurance. So you can see in such a complex law, these kind of things happen, and we've got to figure out a way to square this up so that we actually have to always offer the 10 categories. So that's what we're working on right now. So the feds gave the responsibility to the state to determine a typical employer plan. Originally, the feds were going to decide it. Then they gave it back to us. And I was speaking to you earlier about what our different 4 choices were. And the one that I missed was the largest state employee health plan by enrollment. The bottom line is, when they did a study, the Department of Insurance had Mercer do a study for them, and it was a pretty brief analysis, but what they figured out is essentially we all offered the same thing, but other than the Blue Pride option 5, the other plans were way too expensive. With the exception of the largest HMO plan, that's something that's offered in Nebraska, and nobody even knew about its existence. So they figured, well, if nobody knows about the plan, how are we going to market this to people so that they'll want to get on it if nobody even knows what it is? So they kind of crossed that one off the list to begin with. Okay, and so just a little interplay discussion between the Department of Insurance and Blue Cross Blue Shield is going on right now over how essential health benefits work in some bills that are in the legislature. I don't know if you all follow what's going on in the legislature, and if you don't, hey, that's cool. That happens to be my everyday life for like the last 12 years. But there's some bills, and I thought these were interesting to point this out to you, that there's some bills where option 5 would be impacted. And what that means is if this is the essential health benefit choice for the state, we have to figure out if somebody is mandating cochlear implants, do we cover them? Which we do, but we have some limitations. Our limit on this particular option is 5 years. The problem with that limit is this bill on cochlear implants that was introduced has no limit. So now we have to figure out, what do we have to do? Do we have to square up with this bill and not have a limit on our coverage so that we will comply with what it's asking us to do? So that's one of the issues we're up against. Same thing on medical necessary food. There is a bill in the legislature that mandates that we have to cover medically necessary food for infants that can't digest formulas like most infants can. And so that's not something that we cover. We cover the screening for it, but we don't cover the food. And so, how does that fit into the essential health benefits? And another thing is co-payments and co-insurance and deductibles for primary care physicians versus if anybody has ever gone to a chiropractor or a physical therapist. I know that I haven't personally, but I know some people sometimes have to make 2 co-pays, and one for the office visit and one for the services rendered, whereas when you go to your primary care physician, you just make 1 copay. And so all of these kind of things are going on right now as we live and breathe, that surround things like essential health benefits in the ACA that we need to determine how we're going to implement things if these get enacted at the end of the legislative session. So any benefit mandate, which are the 3 examples I just showed you, cochlear, medical food, co-insurance, co-payments, if that's enacted by the legislature after December 31st, 2011, and it falls outside of the essential health benefits category. So those are considered, a rider, basically, and the costs have to be defrayed by the state. So now the tables have turned for the first time in history where the carriers have to assess the impact not just for the groups, but now we have to tell the Department of Insurance, this is how much we think this is going to cost taxpayers in the state of Nebraska to spread the risk amongst all these people. Before, we only spread the risk amongst the people that were insured. Now, if these things pass, it's going to be spread among everybody. And the state has the flexibility to choose habilitative services, but guess what? They decided, hey, we're not the right guys to choose this. We're going to talk to the carriers. So now the carriers are having to decide, if any of these issues like autism or, anything else would be covered under habilitative. If it's not an issue that's covered under habilitative, if a carrier can assess the financial impact. So we're currently having to do that for the state of Nebraska. They'll go around and ask each major player in the state. They'll ask Coventry, they'll ask UHC, they'll ask us, how much do you guys think this stuff's going to cost? And so that's the landscape now that we're in essential health benefits with the Affordable Care Act. So I just want to make you aware that's the real-world implications of how things are happening now. I think those were all the documents that I had to show you, and we have 10 minutes left. I know we have a hard stop at 1, so I'll try to take your questions. I might not be able to answer them, but we do have somebody that is writing them down, so we can work through Unico Midlands to get answers back to you if it is a question legally that we can answer. But I'll go ahead and open it up for questions. Yes?
So who can go to the exchange? Anybody?
Well, you can go, like I was talking earlier, if you have employer-sponsored coverage or if you're on a government program, you need to go to that place first to have your coverage. And when they do the eligibility enrollment in the exchange, whether you can do it via paper application or you can do it on your computer, they will ask you all of these eligibility questions, and then they'll tell you, you have to take your employer coverage is affordable, you have to go there. No, you're on Medicaid, or no, you qualify for Medicaid, so we need to put you over here. And what that means is you can't go into the exchange and get a subsidy. But right now, it's going to be individuals and small businesses. And I caveat that with the small business exchange proposed rules are nowhere near being out. And so we don't know what a small business exchange looks like yet. We know there's going to be a place for small businesses. We know there's going to be a place for brokers and agents to assist them, but we don't know what all the rules and regs are around how that's going to function.
So if you have a large business and one of your employees, full-time employees, chooses not to accept your insurance, they don't?
They go to the exchange as an individual, or they can go to the outside market. But in order for that penalty to apply, you see, I pointed out every piece of that sentence counts. They have to go to the exchange and get a subsidy. That's the only time you as a large employer are going to get a penalty.
And does that take into consideration their spouse and their spouse's coverage?
It doesn't. It's the employer and their dependents, but I don't believe spouse qualifies under the definition of dependents for the purpose of.
So it's not affordable under us, but it would be under their spouse. That doesn't matter. They can still get a exchange, and then we'd be penalized for that.
Yeah, that's the interesting thing is spouse is separated out from the definition of dependent, and that's why I would encourage you to read these documents, because you would think when you think of the word dependent that they would be included, but it's a child up to age 26.
Wow.
Yeah, and just for clarity purposes, in the state of Nebraska, the way that we're defining a small group is 2 to 50. And we can define a small group from 2 to 50 until 2016. And in 2016, we will have to go to the federal definition of 1 to 100. We do still reserve the option as a state in 2017 to add large employers to the exchange, and that would be employers 101 plus. Clear as mud, I know, right? Great. So, did that answer your question?
Yeah, so if you have I'm sorry, I don't mean to monopolize here, but so if we have 60 full-time employees, our penalty would be 60 minus 30, so you're only penalized for 30?
If they're all full-time employees. So yeah, you would have to do, and this is where it gets sketchy, where I got to start saying I can't answer these questions for you, but you would look at the formula, and that is what it states, full-time employee minus 30 times the amount of penalty.
Full-time employee equivalent?
They are calculated in there for the purpose of determining if you are a large employer. And the other thing I would say is, although that penalty is calculated against an employer on a monthly basis, you don't reconcile that until the end of the year. So the process that would have to happen is each of your employees would go through and say, yeah, I qualified for a premium subsidy, and then it flags, it's theoretically supposed to flag to who does this person work for, and then they use the term certify. They certify that employee back to you and say, okay, does this employee truly work for you, and did you either not offer coverage or you offered unaffordable coverage? And if you did, then after that entire year's worth of time, they reconcile it on the back end for what your penalty is, but only after all of your individual folks have filed their income taxes and you know whether they have received some sort of subsidy through the exchange. So it doesn't happen on a monthly basis. It'll all be, so, I mean, you could be waiting a half a year to another year to figure out if you owe a penalty, and then you'll see in that IRS document, it tells you about the interplay. First, we notify you as an employer. Then you come back and defend yourself. Then we come back and we, reconcile between the records you have and the records we have. Then we will send you a notice and demand for penalty, and then you have to pay the payment. So it talks about that in this December 28th, 2012 IRS document too. They try to spell it out for you. Yes.
Does the exchange have to offer affordable coverage if we send people there? Do they still have to go under the rules of the affordable coverage, the 9.5% of their household income?
No, what the exchange has to offer is minimum essential coverage and essential health benefits. So all of us carriers that would want to participate on the exchange, we have to meet accreditation standards and what's called qualified health plan standards. And so in order for us to participate, we have to offer different levels of actuarial value coverage, and the lowest you can get is 60% actuarial value. That's referred to as a bronze plan. So bronze would be 60, silver is 70% actuarial value, gold is 80% actuarial value, and platinum is 90% actuarial value. So we as carriers, in order to participate in the exchange, have to offer at least silver and gold. That's a standard of participation. But the 9.5 doesn't apply there, but depending on what your income is, you can get some cost-sharing subsidies. Depending on what your income is, you could get what's called the advanced premium tax credit, where money would just go to your carrier that you would choose, and then you might pay, let's say, $50 a month, but they would subsidize you from the federal government to the carrier in the balance of whatever your premium is. Yes.
So with the essential health benefits that we have, the BlueCross 5 or whatever, is that what will be considered the platinum plan in Nebraska? Or are those two things unrelated?
Yeah, not necessarily. Not necessarily, because I don't know what the actuarial value is of all of the benefits as they are today, but I can tell you that's going to change because we have to add the habilitative category, and then we have to figure out what we're doing, whether we actually have to cover pediatric services within the category, or if we can substitute something different and still cover that category, or if it would be a standalone and we just have to marry up with a standalone pediatric service. And all of that will impact actuarial value. So today I can't answer that question. Yes.
The 90-day waiting period, is there a size that that applies to, or is it all employers?
I thought it was all employers, but let me see. Well, they say for plan years, for group health plans or health insurance issuers. So to me, that would be everybody.
Okay.
Yeah.
That's what I thought.
Yeah.
Is there potentially a chance that 50 FTE ruling is going to be changed? Is there a reason that may be changed in the future? Like higher, lower? I can see them going lower, but probably not higher.
You know what? Anything could change. And I'm not trying to skirt the question. Really, truly, anything could change.
Where that's going to be thought out, but boy, that was really.
Yeah, and you got to be really careful. You bring up a really good point because it's 50 and above for the purposes of this penalty. Anywhere else you go, remember I was just talking about the exchange, and I told you in Nebraska we're going to call a small employer 2 to 50, but federally they're going to call a small employer 1 to 100. And if you look at different provisions of the Act, a small employer may be defined in another way, or a large employer may be defined in another way. So you just got to really pay attention to the particular provisions that you're working with. Can it change? Yeah, I think it could. I wasn't anticipating that they put in the 95%, and they just did that through rules. Sometimes they get in a conundrum where they said, oh, we said this in law, but boy, we really screwed this up. We didn't think about how that's going to work out in reality. And one great issue that I think everybody would understand is they, I know you guys have probably heard of navigators, and then they had assisters, and they have brokers. They sort of made a mistake there on how they were going to get their federal money down the pipeline to have people reach hard-to-reach populations because they said certain state programs could not support navigators. And so what they did is they created this other category of assisters, which is nothing. It's the same thing as a navigator, only they created it so they could funnel federal money down. So it's things like that. Once they realize, oops, you know, we cut ourselves short on this one, we got to find a way to get to where we need to be. So I really think that anything could change, unfortunately or fortunately for you. Other questions? We have 2 minutes. Yes.
You have this list of essential health benefits that would require individual and small group products. So I'm assuming that once that's determined, that's going to impact your small group offerings as well, that we can anticipate some of those things being added to our small group coverage.
You can. Yeah, it will definitely. The whole product world going forward with the exchange particularly is going to change because everybody will have to add habilitative, you know, in the individual and small group, and that'll be outside the exchange too. We'll have to provide minimum essential coverage going forward, and for the most part, I think we do now at the 60% actuarial value level, but if we don't, we've got to figure out a way to get people there because you have to offer at least a certain threshold of coverage. So it is going to change.
So does that mean, too, that the in-network providers will look quite a bit different than what they do now?
I think potentially. I don't know that, and I can't really answer that because there's probably 100 people in our plan that work on very specific aspects of each one of these things, and one of those would be networks. So I think everything's subject to change. Everything's on the table, especially if, you know, within the exchange, we've got to get people to the certain actuarial value threshold. We can only go 2% under or 2% over on each one of those 60, 70, 80, 90. So it's not like we can go 95% or not like we can go 87%. We are within a specific threshold of offering coverage, and so it will alter products, at least in the exchange for sure, to meet those metallic levels. Well, it's so nice of all of you to come out today and receive this message. I just want to thank you for being here. It was a pleasure talking to you. Thank you so much.